Let's continue on with biliary and pancreas diseases. This first picture shows you kind of the biliary tree so that you kind of reassociate yourself with that if you hadn't looked at that in a while. Next picture is just kind of an overview picture of the GI tract so you can see how it all hooks together there. We're going to first talk about cholecystitis, which is inflammation of the gallbladder. And this can be broken down into ones that have calculi or stones or acalculous, meaning no stones. But either way, they can have severe inflammation of the gallbladder, one being typically from stones or obstructions in the cystic duct or gallbladder neck or the common bile duct. And if they don't have stones, then they may be caused from biliary stasis, meaning that there's just not good filling or emptying of the gallbladder that's maybe from previous damage. And so those are the two ways that acute cholecystitis is classified. Chronic cholecystitis is really based on repeated, again and again, episodes of cystic duct obstruction. And chronic inflammation pretty much exists quite a bit. Stones are usually present. And over time, the gallbladder becomes fibrotic and contracted. And it has decreased motility. And it also, because of the lack of the gallbladder working, you have poor GI absorption as a result of nutrients and things because of this. These are some of the typical complications that can come from cholecystitis. You can develop pancreatitis. You can get cholangitis, which is bile duct inflammation, or you may get both occurring from a backup throughout the whole biliary tract. And with that type of bile obstruction, you would see jaundice as a usual case. This is just a picture kind of showing you like where the bile duct and the biliary tree is. You can see the gallbladder there in green and the little blue stones that are sitting in the pocket of it, as well as stones that are in the ducts themselves. And when those become obstructed, they can back up all through there and really mess up and cause inflammation throughout the whole biliary tree and malabsorption down into the gut. This is just a big long list of risk factors. Make sure that you really pay attention to those. I feel quite certain that you'll have some test question where you've got to pick out which is the patient that has the worst risk factor. And remember, this is a pretty broad-based list of things that can cause or just be precursors to developing cholecystitis. In terms of diagnostics, this is just a list of labs and other studies that are usually done. In some of the results, you typically are going to have elevated white blood cell counts anytime you have inflammation. If your liver function is abnormal, you will also have alkaline phosphatase and AST and LDH elevated, and those are usually more with severe biliary obstruction. You may have bilirubin levels elevated. If the pancreas is involved, you will often see amylase and lipase levels that are elevated as well. In terms of typical scans or x-rays, abdominal x-rays and or right upper quadrant ultrasound are usually fairly definitive. They may use a HIDA scan if they want to look at the liver as well. And then ERCPs and MRCPs are usually done when they're not really quite seeing the stones or what's going on, and they really want to go in there deeper to just see if there's some unknown cause they can't quite locate on the other types of scans. This is a scan where you can kind of see how obvious it is to see gallstones on a scan. If you have one in clinical that has this, see if they will let you see the actual CT scan so that you can identify those also. Clinical manifestations, and please make sure that you try to remember a little bit of the differences between how does pancreatitis present and how does cholecystitis present, because they typically are on the opposite sides of the body. So with cholecystitis, you'll have episodic or vague upper abdominal pain or discomfort that usually radiates to the right shoulder. Pain is often triggered by eating a big, high-fat or high-volume meal. So when do you think everybody shows up at the ER with cholecystitis? Quite frequently right around holidays. This is very, very common. They also can have signs of anorexia, nausea, vomiting, serious indigestion, gas, belching, feeling a tight abdomen, or tender abdomen, fever, and they may also have some jaundice, clay-colored stools, which are a symptom of jaundice, and then dark urine, and sometimes you may also see steatorrhea. Sorry about that. The main ways of treating cholecystitis is surgical management, and that includes laparoscopic versus traditional. You can see in the picture here where they're doing a laparoscopic procedure. They've got the abdomen blown up so that they can use their instruments to have good ability to visualize. But on some patients, when you're going into such tiny little areas as the bile ducts, you may or may not really be able to get at everything, particularly if something's just, lodged in there real tight and it's hard to remove. So occasionally you'll see people have the laparoscopic version, but they decided midway through to open them up and do an open approach, or a full traditional cholecystectomy where they usually would have a midline incision afterwards. And then, of course, we treat them like a typical abdominal surgical case. But a laparoscopic cholecystectomy usually is a day overnight in the hospital. They usually feel terrifically better. Of course, they've got the puncture sites that they've got to, that have dermabond and are treated, watched for infection and that kind of thing. But they're usually up and at it and mobile and usually going back home in a day or so. So the care is a little bit different between the two. This is more the trajectory for a traditional cholecystectomy. It's the standard pre-op care that we typically see, and it is considered a full operative procedure because they've had the midline incision as well as sometimes puncture sites if they had to go both approaches in the beginning. They are going to require opioids via PCA pump, typically for pain. They may have to have a T-tube and learn how to care for that if they're going to have continual drainage. They often need antiemetics because of the anesthesia and or because they're on opioids that make people nauseated. They may have more of a wound care with that incision, and they might keep them NPO for a period of a day or two and gradually introduce nutritional therapy, with the typical clear liquids, move up to full liquids as they tolerate kind of thing. And then they really want to look at nutritional therapy in general with these patients to make sure that we teach them, healthy ways of eating since they don't have a gallbladder anymore. Non-surgical management, this is not very common, but occasionally a small amount of patients might be put on 2 different kinds of medications that kind of dissolve or stabilize gallstones. And these examples here are usually reserved for patients that just aren't a surgical case because of their overall health or condition. You can see that there is a way to do shockwave lithotripsy, but of course is not usually the preferred thing to do first. But if they can't tolerate surgery, that might be a way to go about it. And then sometimes people may have a percutaneous transhepatic biliary drain that's just put in to kind of drain the area for improvement. Now, in terms of pancreatitis, it's a serious potentially life-threatening inflammation of the pancreas. And I'll show you in just a minute some specific things of why that becomes life-threatening. But pancreatitis is caused because there's excessive pancreatic enzymes. Those actually start auto-enzyming and destroying ductal tissue and pancreatic cells. And they call that auto-digestion. And the actual cells of the pancreas become fibrosed and not very functional after that. Risk factors that contribute to pancreatitis: high alcohol consumption, and especially in men, is a huge risk factor. And high alcohol consumption is a risk factor in both men and women. And a lot of times patients that do have pancreatitis do continually drink even though they've had pancreatitis before. And so they will not always tell you the truth about that, so just know that. And in women, sometimes they will have cholelithiasis and a biliary tract problem and then end up with pancreatitis. And in a small amount of people, they actually may develop pancreatitis several months after having childbirth. This is that autodigestion outlay. And you can see the etiological factors there at the top. Some other drugs and trauma, some other things can cause this same thing. But look at all the necrosis, hemorrhage, necrosis of blood vessels, fat necrosis, edema. And then on both right sides, what do you see? Shock and hemorrhage. So this patient can become extremely unstable hemodynamically and also can die from pancreatitis because of these things. Diagnostic test: this is just a list of things to kind of commit to memory as to what kind of levels of different things would be up and why. And it's typically because of pancreatic cell injury, a lot of them are, or an obstruction to the liver, or the liver being involved. You also will have, usually on imaging, you can see that there's an issue with pancreatitis either by abdominal ultrasound or CT. These are the differences in the pain that I mentioned before. Pain for pancreatitis is severe and constant, and patients will describe it as, it feels like somebody's boring something through my abdomen, like a hot rod or something, because they feel it all the way through their whole body. And it is much more severe after alcohol or a high-fat meal. It can be either mid-epigastric area or left upper quadrant that radiates to the back, left flank, or to the left shoulder. So again, it's mid to more left side for pancreatitis. So try to keep that in mind. And another key symptom is it's always worse when people are lying down flat. So you want to encourage patients to be side-lying or sitting up for some relief of the pain. You want to assess the patients for jaundice or any of this gray-blue discoloration. That's kind of a idea that something is going on in the subcutaneous tissue to cause that. Be very cautious to really document bowel sounds, because these patients, because of all this going on in their cavity around the pancreas, can develop both peritonitis as well as paralytic ileus. So you want to really be doing an absolutely fabulous assessment of the abdominal, but in a gentle way because of all the pain. Other nursing interventions include managing pain, as you can imagine. You want to decrease GI tract activity, so they're going to be NPO. They may have orders for NG tube to suction. Because of that, you're going to really watch them for their electrolyte levels. So they may need IV replacement of calcium and magnesium. They may need hydration with IV fluids. They may need antiemetics, acid reducers. They may need care for their dry mouth because of that as well. And then antibiotics sometimes are ordered, and again the side lying position. Here's just some pictures.